Yes, I don't know if I love it.
Well, good afternoon, CNY Nation. I'm Dr. Randy Fink, streaming to you live from beautiful South Florida, but I am from CNY Fertility in Colorado Springs, and joining me as always from the seat of happiness in upstate New York, none other than Dr. Robert Kiltz. Dr. Kiltz, good day, sir.
Good day to everyone. Another beautiful day in the universe, upstate New York. It's like in the mid 70s. It's beautiful, and I'm loving it every day. It doesn't matter the weather, by the way.
And hello, Becky Ann. Hello, Jamie. Nice to see you guys here today. What you been up to today, Dr. Kiltz? You're in some surgery today.
Well, I've been in the operating room today. I did a laparoscopic myomectomy, took out a very large fibroid in a young lady who's been trying, and taking out this fibroid I really think is going to help a lot. Also did another laparoscopy for endometriosis, failed transfers, and hoping that removing the endo, hysteroscopy, cleaning out the uterus is going to also help with implantation. And then a third laparoscopy, just found a little sort of mild inflammation in the pelvis, some mucus, cleaned that up, did the hysteroscopy, dilated the cervix a little bit. We know that we're going to have to do a transfer under anesthesia because it was a little challenging. And also, what was it? Oh, you were going to do an endometrial receptivity assay to add some other parts to the two failed cycles that she's had transfer-wise. And we're hoping the third transfer with two embryos, the ERA, and we're going to add level 4 immune protocol to help enhance the chances of success.
You know, hi to Melissa and Jamie. Excited to have you both doing your consultations. Hey to Maria and Kaylin. Glad to have you guys here. We're going to be with you today for about 45 minutes or so. You know, Dr. Kiltz, you spent some time with endometriosis today, and hi, Maria. Endometriosis is a lot more common than we think, you know, and there have been plenty of times that I've gone into someone's pelvis for some other reason. Let's say people going to do something with their fallopian tubes or something, and only to find, wow, what a big surprise, they've got endometriosis. While at the same time, other people, you really think that they're going to have endometriosis based on the symptoms, but when you go and look, there's not that much. It's just a little bit there. So, what's been your experience with endometriosis?
Well, I believe that infertility is strictly an inflammatory disorder, and which is actually not a silent disease, by the way, infertility, right? It's screaming at us. And I believe that endometriosis is the leading finding that we see at laparoscopy, and simply cleaning it out, either vaporizing or excising, or in some cases, just finding a light diffuse erythema, even flushing the tubes. And I also do a pelvic wash along with a hysteroscopy DNC can help. But there is a medical treatment. But basically, if you have no pain, no dysmenorrhea with your periods, no painful intercourse, yet you're infertile or experiencing repetitive failed implantation or miscarriages, I believe that endometriosis is likely the culprit in all of this.
Kumar's asking about using PRP at the time of laparoscopy, and platelet-rich plasma is something that's a little newer on the scene in both the aesthetics world and in the fertility world. And can that help with the chances of IVF success?
Well, I think we should be talking more about using PRP at the time of laparoscopy, where we just simply coat the peritoneal surface with PRP after doing a flush and a washout. I think it could be very helpful. In some cases, we're doing intra-ovarian PRP at the same time, and or intrauterine high volume wash of PRP, which I must give Dr. Verdialis a thumbs up on helping us bring that into part of our tools.
All right, good deal. Hi to Tiffany and Maria and Brianna. Nice to see you guys. Glad to have you with us in the CNY Nation here today. Omnitrope, Maria is asking about for people with a low AMH. Omnitrope is a growth hormone analog. And how do we use that, Dr. Kiltz?
So growth hormone or human growth hormone or Omnitrope, and there's some other manufacturers, seems to help improve egg quality, embryo quality. I think we should also talk about it more in men, helping with sperm quality, morphology, motility count, or just everything looks fine, but it's not working because we have to treat both sides. And I don't really know the exact mechanism to most of these. These are all things that someone wrote up a protocol, was showing some success. And so we have found that it's helpful. Maybe for 2 to 4 weeks prior, maybe simply with the stimulation for guys and for eggs and sperm, and maybe even up to 3 months. There is a Somaderm topical. There's the Serovital, which is the oral non-prescription dose. But typically my bet would be the sub-Q is probably the one that we use the most. You may have some experience with some other forms, Dr. Fink, and maybe you could tell us a little bit about what you know.
Sure. Well, so, in general, when we're consulting with folks for fertility, we recommend almost everybody be on Serovital. And Serovital you can get from their website. You can get it from Amazon. You can get it from Costco.
And I think it may be on our website also.
Is it now?
On our supplement.
Okay.
We'll just talk to Will about that and make sure that's happening.
Yeah, good. That would be great. We in the anti-aging medicine world use a lot of Samoralin, which is another one that's injected subcutaneously, and typically you do that with Samoralin for anti-aging. It's 5 out of 7 nights a week you inject it. It's fairly inexpensive, and what it's doing is that it's stimulating your body to secrete its own growth hormone. So in the early days of growth hormone, and growth hormone is really one of those things that keeps us young. And so that's why we think about using it for those with diminished ovarian reserve or for a low AMH, because it may help to stimulate some youth in the ovaries. In the olden days, human growth hormone itself is what we would use, but it's fairly unwieldy. It's quite expensive. And so over time, we've learned some other ways to get your body to make more growth hormone and to do so much less expensively.
And this is where anti-inflammatory protocols reduce inflammation. We use low-dose steroids, low-dose naltrexone, CBD oil, yoga, meditation, acupuncture, massage, and Kiltz's keto is critical in all of this. It really does help tremendously.
It sure does. And MM Rivera, good afternoon to you, asking a good question, something that we've been talking about more and more recently. Do we offer natural cycle IVF? And the answer to that is yes. Dr. Kiltz?
Absolutely. Absolutely. And yeah, Dr. Fink and I were just talking about this last week, and we believe that lower dose protocols are critical and natural cycle IVF is critical. So without any medications, but a trigger shot to time the retrieval. And then the other is using letrozole and or Clomid. And the third is using letrozole or Clomid with the low dose injectables, anywhere between 100 and 200 units of gonadotropins. But yes, I think it can be very valuable.
Yes, indeed. Julita's asking about some of the things that we were kind of just alluding to, some of the things that go along with our immune protocols. And that is the HCG wash, the PRP, and intralipid, something we believe in very strongly at CNY Fertility and part of what we do as reproductive immunologists. Let's talk about those three things. First of all, let's talk about intralipid, because that's integral along with what you got there.
I want to remind all of us that our family building guide is on Amazon. It's a very inexpensive investment that talks in detail about a lot of these things we're talking about today. So you want to gain some more information, and I think you might even go to our website and find a digital copy too. So just because we talk about those things because you may miss something here. And I know reruns are really popular, but that's another place to find more information. But
intralipid goes kind of hand in hand with keto, doesn't it?
Well, intralipids are basically a parental nutrition that's been used, which is fat. Our bodies need fat, and basically it contains fat and amino acids, which are the only two essential products that our body requires. But by using the intralipid fat infusion, it reduces inflammation. And there's some papers out there that talk about this. And keto is a high fat, low carb, low protein diet. So they all go hand in hand for sure.
Yes, indeed. So before fresh transfer, absolutely, right? Before fresh frozen, we want that uterus, we want that body to be as prepared as possible to be able to support the pregnancy.
It's CNY Fertility Centers, by the way, meaning that we don't just do IVF, but for natural pregnancies, for IUI, IVF, fresh or frozen, all of these protocols can be very valuable, including the intralipids.
Yeah, absolutely. Mandy's asking about the COVID vaccine, and during a stim for retrieval, does that mess anything up? Well, we strongly encourage folks to get the COVID vaccine, but one of the medications that you're on at the during that process is prednisone. So we do usually have a recommendation about timing on the COVID vaccine. Doc?
So I don't know the answer to this one. No one really does.
Oh,
I would say,
yeah.
I mean, my answer is it's better to have the vaccine than the virus. And so we're typically recommending the vaccine a few weeks prior to a transfer would be my general recommendation, but I don't think we have any solid answers on this. So ultimately we give our opinions. You do a lot of reading. We're going to support you, whatever your decision is going to be in that one.
We've got our friend Amber with us again today. Amber, glad to have you. She is starting her stim next week, and I believe I saw a little bit earlier that she's 30 years old, and she's debating whether to do 225 or 300 of Gonlef or Follistim with 75 of Menopur, and she is concerned because she wants to have as many embryos as she can in case the first transfer fails. Is there a big difference between 225 and 300?
I think the 225, I consider the 225 and lower low dose, and the and the 300 as our standard dosing. It all depends. Everyone's a little more sensitive to others, but I tend to use a 300 dosing as my low dose and a 150/75 if you're doing gonal Menopur. But I think the 300 is into our standard dose, and 225 and lower is our low dose, and 450 and above or 400 and above would be our high dose.
So Melissa had a laparoscopy for endometriosis, and there wasn't a lot going on. They found a little bit of scarring, and her doc said didn't think it was going to affect IVF, but maybe you can just give your 10,000-foot view there again on what appears to be mild endometriosis in the pelvis as that relates to inflammation and fertility.
Well, we label endometriosis based on minimal, mild, moderate, severe, based on you have a couple of little spots versus a few more spots, and then some spots and scar tissue, and then the severe where it's significant scar tissue, damaged tubes and ovaries and endometriomas. But I think in the minimal side, because even just looking in there and seeing some redness, I think that's endometriosis. And we don't know why it affects some people and not others, because there are women who have babies with endo, and so we don't really know that answer. But I would say that anything you could do to either do a clean out, a wash, it may even be the carbon dioxide, CO2 gas we use to blow up and to dilate the abdomen so we can see and do work in there, may actually be anti-inflammatory. So that's kind of the interesting part to this whole study, that I think that just by doing the scope, finding a little bit, washing it out, does help in the process. Today, the one case I found two small little spots. I vaporized them because they were easy enough to vaporize to be certain they were gone, and there was enough peritoneal surface I could see, and there was nothing deep. I think that's enough.
Mary's asking about turmeric, pineapple, and ginger juice after egg retrieval.
I'm not a big fan of those personally, but if you think about them in some way, they may be an herbal medicine. Herbal medicines we use, they may be anti-inflammatory. I just think that if it's pineapple juice, it's full of sugar, but if it's the desiccated core powder, it may be helpful, but I'm a fan more of the lipids, the Lovenox, the LDN, the keto, maybe even adding things like Plaquenil and Neupogen. Those are going to be the better things. So water, much better.
Indeed. Water, always a good thing. And that's something else that you talk about a lot is hydration. And does some people actually overhydrate?
You can overhydrate for sure. So you got to be careful. We're drink in your thirst, but don't carry around a gallon or two a day. You can get too much oxygen, too much water, too much anything. So we're meant to go days without water, weeks without food, and only a minute without air or two. So focus on the breath. Lots of breathing. Drink some water during the day, but don't go crazy. So I'm going to get back to Amber, by the way, about want you to decide what's probably best, 220, 300. I typically start, again, we do a lot of standard 300s. You start that, you stay on it. I don't typically start lower and go higher. If you're going to do anything and you want to change your dosing, you want to start higher to push the ovaries, then lower the dose. But personally, I have found that pick a dose and stay on it. It does really well. I think that's the best way to go personally.
Today seems to be a good day for Ambers, actually, because we also have Amber Sanders joining us. And good afternoon to you,
hey, Amber.
Our friend. Glad to have you. So it's a good procedural question. She's got two good questions, and the first one is about timing. With how long is it taking now for folks who are coming in for a consultation before they can start cycling?
Well, within a few weeks, but it takes time once we have the conversation to get financial conversation, order your medications, and get you started. I mean, we'd love to be able to get started that day, but it just, there's a lot of little pieces to put together. We want to make sure that you get the very best in order to make this happen for you.
Amber also asks about embryo donation.
Embryos can be donated. There may be ways for people to help pay for some of your travel services or something else. I saw there's a question about selling embryos. We can't sell embryos. We have a nominal fee in order for doing paperwork and the work in order to make this happen. But embryos you can't sell. But we do offer, we are looking for more couples, women, individuals to donate extra embryos, donate extra eggs, donate extra sperm. Donation helps people, and the more we can help more people in this world to continue to make it affordable and accessible to everyone, the better.
Affordable and accessible to everyone, and that's kind of what we do. That's what we believe in. Carly's asking about progesterone levels at the time of a frozen transfer. What kind of numbers are you looking at? And when we test for progesterone, why do we even bother?
Well, we want to make sure that your level is at least above 10. We kind of pick 20 as our sweet spot because there's a lot of variability. We have some over 40. I do not believe there's evidence that level over 40 or at 15, it means bad. There's such a variation in this in our human bodies and our measuring of these things. But in general, we're looking for over 20. I mean, if it's 60 to 80 to 100, you don't need it that high. But I don't think it's detrimental in my opinion.
Okay, got it. Oh, here's something just caught my eye. Actually, Hi, Jenny. Nice to see you. Thanks for being here today. It was good to see you there for your procedure. And I'm gonna go back there to your question in a second. But Destiny caught my eye talking about low dose naltrexone, and you feeling like you just came out of anesthesia. Some people do feel funny with low dose naltrexone, but let me tell you, it is a great medication. Dr. Kiltz, tell us, how did you come upon low dose naltrexone and what's been your experience?
Well, one of my patients called me one day and said, Dr. Kiltz, have you heard of this stuff called low dose naltrexone? I said, no. And I looked it up. I did a lot of research. It's probably about 10 to 15 years ago at least. And LDN's been used by Phil Boyle in Ireland for years. Does a lot with the NAPRO technology, which is a natural fertility. But he's been using it very safely, pre-pregnancy, infertility, anti-inflammatory, and even during pregnancy. Not everyone tolerates. Some people have some side effects, but I would say in general, people tolerate it well. It's compounded. You could do 1 milligram, 2 milligrams, 3 milligrams. We sort of like break it up into 1.5, 3, and 4.5. I think at night it's really nice. But like aspirin, like very low dose steroids, like CBD oil, and not the steroids, but CBD oil, keto, LDN, these are all anti-inflammatory, probably very homeopathic levels anyway.
Really, so much data out there on low dose naltrexone and all the things it does for the immune system. So if you can stay on it, really, please try to do that. The most common side effect I hear about, I do recommend you take it at night, but it can give you funny dreams, especially in the beginning.
And some people switch it to the morning, but lower the dose.
Right.
Half the dose. Start at 1 milligram and move up, but very slowly, or just stay on that. I think that's good. But LDN book on Amazon is really good. There's so much out there. I'm really grateful that I've learned about it.
Let's go back to Jenny, my friend Jenny Petzica, who comes from Italy.
Hi, Jenny.
And lives from Italy by way of Montrose, actually, is what the story was. So she had a procedure. She got 6 mature with 2 fertilized, and we're hoping that they'll make it to day 5. So she's asking about fertilization, and is it related to sperm or is it related to egg?
Both. Everything's always related to the egg. Everything's always related to the sperm. And exactly which is the one that's the issue, no one knows that for sure. But I always say it's both. My husband has bad sperm. Well, that doesn't mean your eggs are perfect either, or vice versa. So that's why we're always working in tandem here. Get the best sperm, the best egg to get the best embryos. In general, though, if you're fertilizing nicely, but they arrest day 3 or after day 3, I think it's maybe more likely a sperm issue, but we don't really know that. This is why I recommend a lot of day 3s, but so day 3s or cleavage or blast stage, which is day 5 or 6, by the way, and sometimes day 7.
Okay, thanks. Forgive me if I'm saying it wrong. Rocky or Reiki asking has found some liver lesions, and so there's a bunch of different things that could be. There's something called focal nodular hyperplasia that can be associated with certain types of estrogen, oftentimes high doses, like in birth control pills. If estrogen liver lesions are found, do we adjust our protocol, and how does that affect pregnancy? How does it affect
birth control pill? It's not estrogen; it's the birth control pill.
Mm-hmm.
So it's like an allergy. It's an inflammatory, localized area of the liver, which is common, and people take the birth control pill. But people don't realize that the birth control pill is not just estrogen; it's got other particles that are used to make estrogen. Plus, most of these are compounded or historically made from plants. So my bet is it has nothing to do with the estrogens we use in general. And I personally don't like to use the birth control pill, but I think these liver lesions are all related to inflammation, same thing as everything else. And it may be cofactors of a low fat diet, eating 3 to 6 meals a day, or some other factor. But the birth control pill also increases your risk of blood clots. It's not estrogen, it's the birth control pill. It may be the estrogen component, but my bet is it's something else other than that.
Let's say hi to oh gosh, I don't know. I'm going to say Shaquana. We'll go with that and pretend like I'm saying it right. Glad to have you here, Ms. Scruggs, asking about tubal reversal. So let's talk a little bit about tubal damage. So she's asking about proximal tubal damage. Those are terms that we throw out there. Proximal means the near, distal means the far. So the proximal tube is the area that is closest to the uterus itself. So tubal reversal versus other things that we can do for proximal tubal blockage.
The proximal obstruction, you need to see whether or not you can open it with a selective tubal cath. Now, there are some people that do more of the proximal tubal repair. I do not do the tubal implantation, and I do not do the Assure removal and reimplant. But there are people that do that and have had success, as long as you have some reasonable proximal tube. But we've gone all the way to the corneal region, but it doesn't work as well. But you need to get the hysterosalpingogram to get a peek at how much proximal tube you might have, or a selective tubal cath to see whether or not you can take an x-ray, see how much tube you have available, and dilate that. I think the proximal damage is often caused by, again, inflammation, endometriosis, adenomyosis, but they can be done. There's some that do proximal tubal repair or corneal damage, really what you're probably looking at.
Okay, good deal. Bree, hey, Bree, glad to have you here. It's a really good question. So you're planning to do a transfer in June, and you're thinking right now about what to do to start to prepare your body for the implant. And I can't applaud you enough for starting to think about that now. And I knew what Dr. Kiltz was going to say to that. Doc?
Family Building Guide, check it out, but keto, keto, keto.
All three words.
Yoga, meditation, acupuncture, slow it down, cool it down, whatever you could do for anti-inflammation. And remember, put the picture of a baby. I mean, that's what this is all about. It's you want baby pictures, you and your family, because the vision board will help be part of the success of what you desire in life. If you haven't read The Secret or The Fertile Secret, one by Rhonda Byrne and one by this guy named Dr. Kiltz, but it's Believe and It Shall Happen. But we want to do everything we can. And this is where maybe laparoscopy, hysteroscopy, ERA testing, all could come into play as additional things, along with talking to one of us and talking about which protocol should you look at.
Tia's asking about fibroids, and that's another very common topic. We see fibroids exist in about 70% of women. She has some small fibroids. What are your thoughts on transfer and implantation?
Well, I don't know what the term small is, but the gal I did a myomectomy on was told she has a small fibroid, and it was about, then they measured at 3 centimeters. I took out about a 6 centimeter fibroid. So I believe fibroids are simply indications of inflammation, all the other things besides surgery you want to do. And in some cases, they should be removed, or they could be removed, and removing them may increase your odds. But definitely if they're impinging on or into the cavity, and if they're greater than 1.5 to 2 centimeters, they're more likely to be an issue than if they're smaller than that. But again, plenty of women have babies with endo and fibroids. Why are you suffering from that, it's a mystery. But I've seen so many fail, remove the fibroids or the endo, and then success even on your own. So I think it's important to get those evaluated, either a pelvic ultrasound or an MRI. Sometimes a 3D ultrasound could be helpful also.
And somebody always has to call Dr. Kiltz during a
We'll
live,
get it
right?
in a few minutes. Yes.
Amber's asking about, okay, so it sounds like you're getting 300 of follistim with 10 of HCG. Sometimes we do 10, sometimes we do 20. So I think that dose of the HCG is...
I recommend the 20. 300 plus 20, probably better. A little letrozole. 10 is usually what I'd recommend. I've been talking a little bit about maybe even increasing the HCG dose a little bit. Might be also beneficial, but go ahead, Dr. Fink, please.
No, I was going to say is it, would you consider it wrong to do 310? So 10 of HCG, and again, this kind of goes back to what we've been talking about, getting lower and lower doses of things in order to reach IVF success using low mini dose protocols. But there's different ways that we do these protocols. As far as 10 of HCG with 300, what are your feelings?
Again, I just, we have our habits. I don't know whether 10 is really the right number. I tend to use 20, but more and more I'm beginning to look at a little higher doses of that HCG. But, technically no HCG or LH is required in these protocols, but it's kind of, we're all fancy chefs. We've got our recommended best
recipes.
Recipes, that's it, yes.
Best recipes. Here's another procedural question from Tessie, who's planning on doing a tubal reversal. When we're scheduling these things, and you know what, I've done a couple of consults over the phone from folks looking for tubal reversals, and those patients go to Syracuse. What's the timing on surgery scheduling once a patient comes through for the consult? How long are folks waiting to get those cases
I don't know that answer. We send it to the OR team. They'll let you know in maybe a month or two, or maybe 6 months. So getting you in there and getting you moved forward is the best we can do right now. But it's kind of like, do I do reversal or IVF? I wish I could do more of them and get them done faster. It takes a little bit of time to get those in the books and get them going for you. So I apologize.
Question. The lesson there is the sooner you know that you want to do it, the better. So get plugged into the system. Let's see what we can do to help.
There's a question from Kiara regarding PCOS and kidney disorder, which prediabetes is very common, by the way. And what's Kiltz going to say on that one? Keto, really helpful. One meal, one snack, infinite naps, lots of prayer, by the way. Oh, one nap, by the way. Lots of prayer, meditation, positivity. And the keto really does the trick. I've seen it. PCOS is a metabolic disorder due to a high glucose environment or other plant particles that are damaging us, I think. So look at my stuff. You might find it very helpful, and talk to your doctor. I talked to a kidney specialist today. He said, "Doctor, I've never heard this stuff. I'm going to try it because they're infertile."
Wow. See there? Hey, speaking of timing of laparoscopy, and Kaylin asks, diagnostic laparoscopy, do you really want to think about that before retrieval or before transfer?
It could be either. It could be either one. It may be that removing endo scar tissue, one, helps you get pregnant naturally. Number two, it may improve the egg quality, embryo quality. And number three, doing it before transfer, I think is very important, because I always combine a hysteroscopy with an endometrial scratch or a mild light D&C clean out, and the laparoscopy, wash things out, flush things out, which I think can be very helpful. But you could do it before retrieval. If you have severe endometriomas, you have to be careful, because the more endometriomas you take out, the more damage you do to the ovaries. So you have to be really careful. I typically just open and drain them, by the way.
So here we are, about 35 minutes past the hour, CNY Nation. So glad to have you with us. We've got a little bit more time today.
10 more minutes. 10 more minutes.
10 more minutes. We got some great questions here, and I want to hit two of them right now. Bella got 14 embryos on her retrieval, but only 2 of them made it to blast, or day 5 or 6. She'd like to know what causes this. Why is this happening?
Well, we don't really know, but either the culture conditions in the laboratory are not as good as your uterus, and I believe that's true always. Second, there may be some sperm issues that affect the blastulation of an embryo, or they're really just bad embryos, and that's it. But I've seen so many people that have a lot of great eggs, a lot of great fertilization. They get a lot of great day 3 embryos, but they don't make many blasts. My opinion.
You say bad embryos. What do you mean by that?
Well, if it doesn't make a blast, it doesn't make a baby, it's either a bad embryo, or if you transfer it, it's a bad implantation. So we just use these very loosely, these terms, right? It's either bad egg, bad sperm, bad embryo, or bad implantation that causes all fertility issues. Okay? So meaning that now, even if I look at it and it looks like a great star, or it doesn't look like a great star, it looks ugly, that doesn't mean it's good or bad. You can only really measure it whether or not it becomes a baby or not. But ultimately, if an embryo stops growing in the lab, it could either be a bad embryo, bad conditions, but we don't know which one it really is. So if what you did didn't get you there, either do it again and do it the same, or do something different. That's been my motto in this. Different is the key to get you to where you're going. If you keep doing what you're doing and it's not working. So again,
my dear friend, Dr. Magarelli, says nature has a way of selecting those embryos, of selecting those that are going to continue.
Right. But remember, we're doing something completely artificial. And so the laboratory, in my opinion, even PGS testing, an abnormal embryo transferred, I've seen normal babies. Normal embryos, I've seen miscarried.
And speaking of that, Fionn has a question here, and I don't think I can, no, I can't bring it up. But if you want to try to put it on the screen, it's from 4:26 p.m. Abnormal tested day 5 embryo. Is there a chance that could still become a healthy baby? And if there's no more normal tested embryos, would you implant an abnormal embryo?
Here it is. Look, every sperm, egg, and embryo has the possibility of becoming a baby if it's put in a uterus. If it's never in a uterus, you never know what its potential is. You could kick out a kindergartner who didn't do so well on the tests, but that's not the best way to give a human being the chance of being successful in life, in my opinion. Again, I've seen plenty of normal embryos miscarry or not implant, and even testing the tissue were abnormal. So then the question is, how accurate is the testing? I personally don't believe it's as accurate as we think it is. And I've seen plenty of abnormal embryos transferred in normal babies. So that said, is what test in medicine or life is 100% anyway?
Yeah.
None.
Yeah. Yep, for sure. Let me address this one from Samantha, who started her meds, but was just told her thyroid was a little bit high and wants to give meds to bring it down. Never had a problem with it before. Well, it doesn't necessarily mean that you have thyroid disease. One of the things that we address in the IVF process is thyroid wellness. We like to see that number. Some people say 2.5, some people say 2.0. You go with 2, Dr. Kiltz?
2.5. 2.5, I think is good, but I think you're right. Whole body wellness is what we're all looking for, but it's just an indication of inflammation. But sometimes when you're doing these processes of treatments and drugs, even the cross reactivity of the testing may give us a false number anyway, but 25 to 50 of thyroid, synthroid, levothyroxine is good. Some people recommend the desiccated armor thyroid as another option. Anti-inflammation is what we want, but I think they are important.
Rain has got a question about a 10 millimeter submucosal fibroid. Submucosal means it's inside the cavity of the uterus and taking up space where the baby may implant. 10 millimeters.
If it's in the cavity, it could be a problem. If it's not, 10 millimeters is hard to get to if it's not impinging on the cavity. But in my opinion, it's just another marker of inflammation.
But if it's on the inside of the cavity, I would say yes. It's very straightforward to remove a small fibroid like that. Really, just takes it's a few minute procedure that can be done under sedation. So let's see, where are we? About 440.
Let's get Millicott, and I think that progesterone is fine. By the way, for a frozen transfer, 26 is great. By the way.
Okay. Megan is asking about the ideal sizes of follicles that we're looking for at trigger. So that's a good question. 16, 18, what do you say is mature, Doc?
Between 16 and 18 is our first level of maturity. Sometimes we're looking for 18 to 22. DOR, fewer follicles, we tend to trigger at about 16 to 18. But this is the mystery. These are, again, fancy chef observations more than anything. That's our trouble. If it works with whatever you did, we often don't go back and look hard enough to know. But I would say that it's quite variable, and I believe that 16 to 18 is where we start from. If you have a bunch in the 13 to 14 range and you have 2 at 17, I would push them a few more days to get those other smaller ones a little bit larger.
More mature, right? Likely to get more. You'd rather sacrifice 2 bigger ones to get 6 smaller ones that will move on to mature, right?
Correct. Right.
Yeah.
Right.
Yeah.
Right.
Thoughts on an estrogen producing, this comes from Tanya, thoughts on an estrogen producing cyst. Best course for getting rid of it, and if the birth control pill doesn't work in 2 weeks, stalling my transfer.
I usually say either do the birth control pill and just follow up in a week. Quite often, I don't care that much about these estrogen producing cysts anyway. I would say that we worry too much about cysts. Quite often, it's just a matter of get stimming, and we drain them at retrieval. If you're worried about it, we could stick a needle and drain it and then get started. But quite often, we add estrogen in the luteal phase also in order to improve your environment. So I just think we got too many parameters that we're worried about, and I don't think it's a big issue.
I got to ask you this one because this is going back to an old favorite. Licia asks about, she says, her doctor told her not to do keto because she doesn't have a gallbladder.
I don't even think the gallbladder is really the most important thing for fat metabolism personally. I think the gallbladder has more to do with hemoglobin and bilirubin metabolism and dumping it out of our bodies personally. But you still make all the bile that goes right into the GI tract from the liver directly. Keto is like the best thing. Kiltz's keto lifestyle is number one, in my opinion. It's one meal at night. It's one snack, maybe. It is high fat. By reducing the amount of food in your body and getting off the treadmill, it's the most amazing thing you can ever do. But keto is the healthiest thing for all of us. I don't care what you're suffering from, whether you have appendix or not, a gallbladder or not. If you've had any GI surgery to make your stomach smaller, it does not matter. This is the home run that solves almost every disease. Intermittently feasting, that means one meal a day, is the home run.
The home run. Well, speaking of home run, we're entering the home stretch here. We got to end a little bit early today, but I tell you what, let's add one more question. I was going to let
I
Dr. Kiltz
picked
pick it.
NCAC. How about you read the question and we'll finish up on this one, Dr. Fink.
All right, 3 early losses. So between about 5 weeks and 5 days and a week later, 6 and 5, she had 2 PGTA tested embryos, was on steroids and blood thinners. Everything seemed to be good. All blood work good except for low level antiphospholipids, and looks like antiphospholipid levels and MTHFR mutation. What else can she do? I like this to get an earthside baby.
Well, one is I'd go to 100 milligrams of aspirin. I'd do Lovenox at least 30 twice a day, maybe 40 twice a day. The prednisone, 10 milligrams twice a day, maybe even 15, by the way. This is where weekly intralipids through at least 14 weeks, then every 2 weeks to 28 weeks, and then weekly after that. And then consider intravenous immunoglobulins, at least 20 grams, starting a week prior to transfer, or 2, and every 2 weeks to 14 weeks is the one I would say that's the very best. And then things like Plaquenil, 200 milligrams once or twice a day, Neupogen, approximately 60 micrograms a day, are kind of our go-to. And don't forget PRP, HCG, and Neupogen washes as options. And also the HCG boosters. I don't love them because it may be a false positive pregnancy test, but I think it could really, really be helpful. But the and Kiltz's keto. It really is the most amazing thing I've ever done. I do carnivore keto, but you can do it as a vegan, vegetarian, Mediterranean, or whatever you want to do. Be careful about too much fish because it contains mercury and many other toxins that I think come from the waters of the world, including all the drugs we consume. We pee into the water and they get right out into the waters of the world, and we are drinking more drugs than you ever imagined. So that's kind of and don't forget laparoscopy, hysteroscopy for endometriosis and remove those fibroids. So, but thank you, Dr. Fink, and to everyone, Lena, Mulakat, Ariana, let's see, Ambers, Ranisha, Marie, and I wish we can just see and say hello to every single person joining us, Dr. Fink. So thank you for doing what you're doing today.
What a great group of people. Thank you all for being with us. And gosh, blessings to each and every one of you. The CNY Nation comes back to you live with a live just about every day. Join Dr. Kiltz, won't you, on his Sunday morning house call and conversations with Kiltz and Fink on Thursdays. Pick up that family building guide on Amazon and a digital copy on our website. And don't forget, move forward every day with a positive thought. Start your day with thankfulness for what we have. And that is how we get there.
God bless you, Dr. Fink, and to everyone, God bless you. I'll see you guys on Sunday, if not before. Bye.
So long.